Cardiomyopathy, disease of the heart muscle. Cardiomyopathy is a group of diseases that directly affect the myocardium or heart muscle. These disorders change the structure or function of the heart and reduce its ability to pump blood effectively. There are several major types of cardiomyopathy. Hypertrophic cardiomyopathy occurs when the heart muscle becomes abnormally thick. The thickened muscle can make it difficult for the ventricles to fill and may obstruct blood leaving the heart. This condition is often genetic and can cause chest pain, shortness of breath, fainting, arrhythmias, or sudden cardiac death. Dilated cardiomyopathy occurs when one or more chambers of the heart, especially the left ventricle, become enlarged and weakened. Because the ventricle cannot contract effectively, the heart pumps less blood to the body. This can lead to fatigue, shortness of breath, swelling, arrhythmias, and heart failure. Causes may include genetic conditions, viral infections, alcohol, medications, or toxins. Restrictive cardiomyopathy occurs when the heart muscle becomes stiff and cannot relax normally. The ventricles may still contract relatively well, but they cannot fill with enough blood between heartbeats. This can cause shortness of breath, fatigue, swelling, and reduced cardiac output. Restrictive cardiomyopathy may result from scar tissue or infiltrative diseases, such as amyloidosis. Arrhythmogenic cardiomyopathy occurs when normal heart muscle is gradually replaced by fatty or fibrous tissue, often affecting the right ventricle. This abnormal tissue interferes with the heart's electrical system and increases the risk of dangerous arrhythmias. Patients may experience palpitations, fainting, or sudden cardiac death, particularly during physical activity. Although each type affects the heart differently, all forms of cardiomyopathy can interfere with circulation and may eventually lead to heart failure, abnormal heart rhythms, blood clots, or sudden cardiac death. Cardiomyopathy, disease of the heart muscle. Cardiomyopathy is a group of diseases that directly affect the myocardium or heart muscle. These disorders change the structure or function of the heart and reduce its ability to pump blood effectively. There are several major types of cardiomyopathy. Hypertrophic cardiomyopathy occurs when the heart muscle becomes abnormally thick. The thickened muscle can make it difficult for the ventricles to fill and may obstruct blood leaving the heart. This condition is often genetic and can cause chest pain, shortness of breath, fainting, arrhythmias, or sudden cardiac death. Dilated cardiomyopathy occurs when one or more chambers of the heart, especially the left ventricle, become enlarged and weakened. Because the ventricle cannot contract effectively, the heart pumps less blood to the body. This can lead to fatigue, shortness of breath, swelling, arrhythmias, and heart failure. Causes may include genetic conditions, viral infections, alcohol, medications, or toxins. Restrictive cardiomyopathy occurs when the heart muscle becomes stiff and cannot relax normally. The ventricles may still contract relatively well, but they cannot fill with enough blood between heartbeats. This can cause shortness of breath, fatigue, swelling, and reduced cardiac output. Restrictive cardiomyopathy may result from scar tissue or infiltrative diseases, such as amyloidosis. Arrhythmogenic cardiomyopathy occurs when normal heart muscle is gradually replaced by fatty or fibrous tissue, often affecting the right ventricle. This abnormal tissue interferes with the heart's electrical system and increases the risk of dangerous arrhythmias. Patients may experience palpitations, fainting, or sudden cardiac death, particularly during physical activity. Although each type affects the heart differently, all forms of cardiomyopathy can interfere with circulation and may eventually lead to heart failure, abnormal heart rhythms, blood clots, or sudden cardiac death. Causes, risk factors, and major complications. Cardiomyopathy can develop from inherited conditions, acquired damage, or causes that remain unexplained. One important risk factor is genetic inheritance. Some forms of cardiomyopathy are passed through families, so a family history of cardiomyopathy, abnormal heart rhythms, or sudden cardiac death may increase a person's risk. Viral infections can also damage the heart muscle. When a viral illness causes inflammation of the myocardium, the condition is called myocarditis. This inflammation may weaken the heart and eventually lead to cardiomyopathy. Coronary artery disease and a previous myocardial infarction can reduce blood flow to the heart muscle. When heart muscle is damaged by prolonged ischemia or a heart attack, it may become weak, scarred, and less able to contract effectively. Long-standing hypertension also places continuous pressure on the heart. The heart must work harder to pump blood against increased resistance. Over time, the muscle may become thickened, enlarged, and eventually weakened. Autoimmune and infiltrative diseases can directly affect the myocardium. Conditions such as lupus, sarcoidosis, amyloidosis, and hemochromatosis may cause inflammation or abnormal material to accumulate inside the heart muscle. This can make the myocardium stiff or interfere with normal contraction. Alcohol and cocaine can have toxic effects on the heart. Heavy or prolonged alcohol use may weaken and dilate the heart muscle. Cocaine can increase blood pressure, constrict coronary arteries, trigger dangerous dysrhythmias, and cause myocardial damage. Diabetes and obesity increase cardiovascular stress. They are associated with inflammation, hypertension, coronary artery disease, and increased workload on the heart. Together, these factors can contribute to structural and functional changes in the myocardium. Certain chemotherapy medications can also damage cardiac cells. This toxicity may appear during treatment or develop months or years later, so patients receiving cardiotoxic medications may require ongoing monitoring of heart function. Regardless of the cause, cardiomyopathy may progress to several serious complications. Heart failure develops when the heart can no longer pump enough blood to meet the body's needs. Patients may experience fatigue, shortness of breath, reduced exercise tolerance, and fluid retention. When pressure and fluid back up into the lungs, pulmonary edema may occur. This can cause severe shortness of breath, coughing, low oxygen levels, and respiratory distress. Changes in the structure of the heart can also disrupt its electrical pathways. This may lead to atrial or ventricular dysrhythmias, causing palpitations, dizziness, fainting, or sudden collapse. Poor blood flow and abnormal movement of blood inside enlarged heart chambers can promote clot formation. These clots may travel to the brain, lungs, or other organs, causing thromboembolism, stroke, or pulmonary embolism. If the heart becomes severely weakened, cardiogenic shock may develop. In this emergency, the heart cannot maintain adequate blood pressure or tissue perfusion. The result may be confusion, cold skin, reduced urine output, organ dysfunction, and multi-organ failure. The most dangerous complication is sudden cardiac death, usually caused by a life-threatening ventricular dysrhythmia. The key point is that cardiomyopathy has many possible causes, but early recognition, careful monitoring, and appropriate treatment can slow disease progression and reduce the risk of severe complications. Diagnosis, treatment. Diagnosis begins with a detailed medical history and physical examination. The healthcare provider asks about fatigue, shortness of breath, chest pain, palpitations, fainting, swelling, and reduced exercise tolerance. Family history is also important because some forms of cardiomyopathy are inherited. An electrocardiogram, also called an ECG, records the electrical activity of the heart. It can identify abnormal heart rhythms, conduction problems, and signs that the heart chambers may be enlarged. An echocardiogram uses ultrasound to show the structure and movement of the heart. It helps measure chamber size, wall thickness, valve function, and the strength of the heart's contractions. It also provides the ejection fraction, which estimates how much blood the left ventricle pumps with each contraction. A chest X-ray may show an enlarged heart or fluid collecting in the lungs. Blood tests can help identify contributing causes and complications. These may include BNP or NT-proBNP to evaluate heart failure, troponin to assess myocardial injury, and tests of kidney function, thyroid function, electrolytes, inflammation, and iron levels. Cardiac MRI provides detailed images of the myocardium. It may reveal inflammation, fibrosis, scar tissue, or infiltrative disease that is not clearly visible on other tests. Genetic testing and family screening may also be recommended when an inherited form of cardiomyopathy is suspected. The main goals of treatment are to relieve symptoms, improve heart function, slow the progression of the disease, prevent hospitalization, and reduce the risk of serious complications. Treatment begins with correcting or controlling the underlying cause whenever possible. This may include treating hypertension, diabetes, coronary artery disease, infection, or another medical condition that is placing stress on the heart. Lifestyle management is also important. The patient may be instructed to reduce sodium intake, monitor daily weight, remain physically active within prescribed limits, stop smoking, avoid cocaine and other illicit drugs, and limit or avoid alcohol. Fluid restriction may be ordered when fluid retention is severe. Medications are selected according to the type of cardiomyopathy, the severity of symptoms, and the patient's overall condition. ACE inhibitors and angiotensin receptor blockers, also called ARBs, lower blood pressure and reduce the workload placed on the heart. They may help slow disease progression and improve cardiac function. Some patients may receive an ARNI, such as sacubitril with valsartan. This medication helps reduce strain on the heart and is commonly used in selected patients with heart failure and reduced ejection fraction. Beta blockers, such as carvedilol or metoprolol succinate, slow the heart rate, reduce oxygen demand, control some dysrhythmias, and allow the ventricles more time to fill. Diuretics, such as furosemide, help the kidneys remove excess sodium and water. This reduces swelling, pulmonary congestion, and shortness of breath. Because diuretics may alter electrolyte levels and kidney function, close monitoring is required. Mineralocorticoid receptor antagonists, such as spironolactone or eplerenone, may reduce sodium and fluid retention and improve outcomes in selected patients with heart failure. SGLT2 inhibitors, such as dapagliflozin or empagliflozin, may also be used in heart failure. These medications can reduce hospitalization risk and improve cardiovascular outcomes, even in some patients who do not have diabetes. Antiarrhythmic medications may be prescribed when abnormal heart rhythms are present. These medications help control the heart rhythm, but they require careful monitoring. The overall nursing goals are to maintain adequate oxygenation, protect cardiac output, reduce the workload on the heart, relieve symptoms, and identify complications as early as possible. Nursing assessment begins with breathing and oxygenation. Assess the patient's respiratory rate, depth, rhythm, and effort. Monitor oxygen saturation and observe for increasing shortness of breath, difficulty speaking, restlessness, or the use of accessory muscles. Position the patient upright when breathing is difficult and provide oxygen as prescribed. Next, assess the heart rate and rhythm. Monitor for tachycardia, bradycardia, irregular rhythms, premature beats, and other dysrhythmias. Ask the patient about palpitations, dizziness, fainting, or the feeling that the heart is racing or skipping beats. Continuous cardiac monitoring may be required when the patient is unstable or at increased risk for ventricular dysrhythmias. Blood pressure must also be monitored carefully. Hypertension increases the workload placed on the heart, while hypotension may indicate reduced cardiac output and inadequate tissue perfusion. Compare blood pressure changes with the patient's symptoms, mental status, skin temperature, urine output, and activity tolerance. Auscultate the lung sounds for crackles, wheezes, or diminished breath sounds. Crackles may indicate fluid backing up into the lungs and can be an early sign of pulmonary congestion or pulmonary edema. Worsening breath sounds should be reported promptly, especially when accompanied by reduced oxygen saturation. Assess for peripheral edema and jugular venous distension. Swelling of the feet, ankles, legs, or abdomen may indicate fluid retention and worsening heart failure. Jugular venous distension may reflect increased venous pressure and right-sided congestion. Accurate fluid monitoring is essential. Measure intake and output and evaluate urine production. Weigh the patient every day using the same scale at approximately the same time and in similar clothing. A rapid increase in weight may indicate fluid accumulation before severe swelling or breathing difficulty becomes obvious. Assess the patient's overall symptoms and functional status. Ask about fatigue, weakness, chest pain, palpitations, dizziness, fainting, shortness of breath, and changes in exercise tolerance. Compare the patient's present abilities with the usual baseline. Even a small decline in activity tolerance may be an early sign that cardiac function is worsening. Patient teaching is a major part of cardiomyopathy management. The patient should take all medications exactly as prescribed. Heart medications should not be stopped, skipped, or changed without consulting the healthcare provider. Abruptly stopping some medications may worsen heart failure or trigger dangerous changes in heart rate or blood pressure. Teach the patient to monitor weight and swelling at home. Weight should be checked every morning after urination and before eating, using the same scale. The patient should report rapid weight gain, increasing ankle or abdominal swelling, tighter clothing, or worsening shortness of breath. A common reporting guideline is a gain of more than 2 to 3 pounds in one day or more than 5 pounds in 1 week, but the patient should follow the specific instructions given by the healthcare provider. Sodium and fluid restrictions should be followed when ordered. Excess sodium causes the body to retain water and can worsen edema, pulmonary congestion, and the workload on the heart. Patients should learn to read food labels and recognize high-sodium foods. Fluid intake should only be restricted according to the prescribed plan. Patients should keep all follow-up appointments and scheduled tests. Cardiomyopathy can change over time, even when symptoms appear stable. Regular visits allow the healthcare team to evaluate heart function, review medications, monitor laboratory results, and adjust treatment before serious deterioration occurs. Activity should be balanced with adequate rest. Encourage the patient to remain active within the limits recommended by the healthcare provider, but to avoid overexertion. Activities may need to be divided into smaller steps with rest periods between them. The patient should stop and seek guidance if activity causes chest pain, severe shortness of breath, faintness, or sustained palpitations. Additional teaching includes stopping smoking, avoiding cocaine and other illicit drugs, and limiting or avoiding alcohol as directed. The patient should follow a heart-healthy diet, remain current with recommended vaccinations, and bring an updated medication list to every healthcare visit. The patient and family must also know which symptoms require immediate medical attention. Severe or rapidly worsening shortness of breath is an emergency, especially when it occurs at rest or while lying flat. The patient may be developing pulmonary edema or severe heart failure. New, severe, or persistent chest pain, pressure, or tightness requires urgent evaluation because it may indicate myocardial ischemia, worsening cardiac stress, or another serious cardiovascular event. Fainting, also called syncope, should never be ignored. It may result from a dangerous dysrhythmia, severe outflow obstruction, or a sudden reduction in cardiac output. Near fainting accompanied by dizziness or weakness also requires prompt assessment. Sustained palpitations require immediate attention when the heartbeat remains rapid or irregular, or when palpitations occur with dizziness, chest pain, shortness of breath, weakness, or fainting. Warning signs of pulmonary edema include sudden severe breathlessness, crackles, coughing, low oxygen saturation, restlessness, and pink frothy sputum. Warning signs of cardiogenic shock include low blood pressure, cold or clammy skin, confusion, weak pulses, reduced urine output, and signs of poor organ perfusion. These are medical emergencies. A patient who receives a shock from an implantable cardioverter defibrillator, or ICD, should follow the emergency plan provided by the cardiac team. Medical help is especially urgent when the shock is followed by chest pain, breathing difficulty, fainting, persistent palpitations, or more than one shock. Even when the patient feels better afterward, the event should be reported and evaluated according to the provider's instructions. The final message is simple: recognize changes early, protect cardiac output, and prevent sudden complications. Careful assessment can reveal deterioration before it becomes an emergency. Medication adherence and home monitoring improve outcomes. Clear patient education supports safe self-care. When serious warning signs appear, act quickly and obtain immediate medical assistance.